Welcome everyone. We'll just wait a few more seconds to let the lobby empty into the webinar. Thank you everyone for joining. Everybody would be so kind to make sure their microphones are on silent. That'd be great, thank you. We're very excited to have such a wide attendance and such a full attendance today. So it looks like there's still people in the lobby coming in. So we'll just wait another couple of seconds and then we'll get started. Fantastic. Welcome, everyone. Let's make a start. We've got a lot to get through, and I'm sure you're all very excited and curious about this content today. So thank you, everyone, for joining this webinar, this update webinar on genetic testing to guide the use of Clopidogrel after stroke and TIA. We are very happy to have such a full room and so many people joining us today. This is a project that we're very excited about and that we think is really important for the NHS and for stroke services. I'm delighted to be joined by my colleagues, David Hargroves and Vicky Chaplin, and they'll be speaking alongside me today, and you can see the agenda on the screen. We are very keen to share what we are doing in this pilot project to better understand how the NHS can implement genetic testing to guide the use of Clopidogrel in stroke following the recent NICE guidance. And we're very keen to get your thoughts and feedback and questions on this as well. As you can imagine, this is a very new way of delivering healthcare, trying to bring genetics really to the clinical front line and make precision medicine part of everyday care. And that's very exciting from an innovation perspective and also very exciting from a patient's perspective because it really has a significant impact on care and outcomes. So as you can see, the agenda is on the screen. Vicky will be starting to give you a little bit of background on the NHS Genomic Medicine Service, maybe a service that some of you are not familiar with, so it'd be great to get a little bit of an introduction on that. Dr. David Hargroves, who's the National Clinical Lead for Stroke, will then provide the clinical context and background to this and some of the clinical relevance for this new NICE guidance. And then I will speak for the bulk of the time about the pilot project that we're running at the moment across several sites in England and what our approach is as well as the outputs. And we'll finally end with Vicky sharing some further activities that are ongoing at a national level that will support implementation. We've purposely tried to leave time at the end for questions because we are very keen to get your thoughts and feedback. This is new, this is innovative, and it's important for us to be guided by all of you and hear your thoughts as part of this. So please feel free to get your questions into the chat, and I will try to curate as many as I can at the end of this, at the end of the presentations. This webinar is going to be recorded, so if any of your colleagues could not join for any reason, then we will make sure we share this through our website as well as via email with you, so you can share it with your colleagues who may have not had an opportunity to join us today. Fantastic. There are still people joining, which is really, really good. And again, just confirms how this is clearly a topic that people think is important, and that's really, really reassuring for us. So without further ado, I'm going to hand over to Vicky to share her slides and give us an introduction to the NHS Genomic Medicine Service. Thank you, Vicky. Over to you.
Thanks, Fideo. Hi, everybody. Really great to be discussing this today. Hopefully, are my slides visible?
They are, Vicky. Thank you.
Thank you. So I'm Vicky. I'm the Senior Clinical Lead in the Genomics Unit at NHS England, and I'm a pharmacist by profession. And what I wanted to do, just to kick off, as Deirdre said, we've got a really wide group of people here, and just make sure that everyone's aware of what the NHS Genomic Medicine Service is, just to give that bit of context around genetic testing as it stands at the moment in the NHS. So the NHS Genomic Medicine Service, which we commission nationally, has been around since 2018. And we offer genetic testing for patients and public in the NHS across England. And we do that via 7 NHS genomic laboratory hubs, some supporting genomic medicine service alliances who give clinical and professional support to that implementation. And of course, we have our clinical genomics services. a key aspect of that is the fact that this is a nationally commissioned service. So when we commission a genetic test, it is available across the country in all places. So the tests that we commission can be found on the NHS England website under the National Genomic Test Directory. So this is just a snapshot of that screen. It is typical NHS format at the moment, and in an Excel spreadsheet that we're working on digitizing that. But hopefully that provides some insight into the tests that we deliver. And there's quite a lot on there. We've got 3,200 rare disease tests and over 200 cancer clinical indications that we provide genetic testing for. You can see at the top that as part of this process, when we consider tests that go on the test directory, we have expert test evaluation groups. And as I've said, a lot of these genetic tests fall under what we would call rare and inherited disease and cancer. But an increasing area that we're starting to see more now is pharmacogenomics. And of course, that has big relevance to what we're going to talk about today. So at present, you won't see a separate pharmacogenomic test directory on there, but some of those tests are within the test directory supporting various indications such as adverse reactions with cancer medicines and a test to predict risk of adverse reactions with certain antibiotics. So they are in there, and we review them via a national application service. Anyone can apply, and we review them through this process. However, another really important area where, of course, we hear about tests is through NICE. And obviously, we have now this NICE guidance for the CYP2C19 testing in stroke, and we'll talk about that more today. Just as a bit of context, obviously we don't have time to go into kind of pharmacogenomics and the whole basis behind it, but when we're thinking about it, all we're thinking about is the pharmacology of medicines, which hopefully we're all familiar with when we're thinking about what's suitable for our patients. And basically now we've got this extra tool, which is their genomic profile. And by using that and thinking about the pharmacology of the medicine, we can really work towards having more safe and effective medicines that are tailored to variations in individuals' genes. And by doing that, we can hopefully get better outcomes for our patients. So in terms of our approach to genomics, we released a national strategy in 2022, and I won't go into all of it, but I suppose what I really wanted to highlight, and I've already said that pharmacogenomics, we can see it increasing. We do have a focus, particularly in the second theme, about really starting to think about delivering more equitable genomic testing across cancer and rare and inherited diseases we do, but increasingly in common diseases, and that includes precision medicine, pharmacogenomics, really thinking about more effective use of medicines and reducing adverse drug reactions where we can. And to support that, we're also working on having a pharmacogenomic strategy to support this, recognising that we are going to see an increased number of these tests used. And a key aspect of that strategy I just highlighted, and as Vidya touched upon before, is we're really seeing now genomics coming out of kind of the specialist area and more into the mainstream. And this test that we're going to talk about today is a really great example of that. So our long-term vision is that individuals will have access to pharmacogenomic profiles as part of their NHS health record, and that will help them optimise the use of their medicines throughout their lifetime. And the test we're going to talk about today is really, is going to be a fantastic example and starting point for us really seeing that implementation into mainstream practice. So as it stands, we're really kind of starting up and focusing on the groundwork and the foundations that we need to deliver this. And I think we'll learn a lot from this pilot, both not just in stroke, but across the board in terms of how we can implement pharmacogenomics for our patients. And a key focus at the moment is thinking about implementation next year. And then just to highlight, which will no doubt come up with the pilot, as part of this and to support this, we have what we call genomic networks of excellence. And these networks of excellence are there to help to bring together evidence and teach us about how to implement this into NHS practice effectively. And part of that, one of those is the Pharmacogenomics and Medicines Optimization Network of Excellence. And that's part of the work that we're going to talk about today. The pilot is a really important funded work package as part of that. So that learning can come back to us as we make our commissioning decisions moving forward. And then just to highlight, you probably have seen on the NICE guidance page that this pilot that we are going to talk about today has been highlighted, and as I've said, we were really looking forward to learning from it about implementation, so we can use that in our commissioning decisions and delivery of testing going forward. And with that, I will pass over to David, I think.
Great, thanks very much, Vicky, and welcome everybody to this webinar. So for those who don't know me, my name is David Hargroves, and I'm a stroke doctor from the South East Coast and the National Clinical Director for Stroke. So it's a real pleasure to speak with Vidya and Vicky on this really important topic. Thank you, Anthony, for sharing the slides. I'm going to be honest from the start that when the NICE guidance dropped, I, like many of you working in frontline stroke medicine, the first thing I thought was, how on earth are we going to deliver this? This is going to be a real problem for stroke teams up and down the country. And then, of course, as I've been over the last 6 months working with Vicky and Vidya, in fact, I've changed my tune to not how we're going to make this work, but why have we not been thinking about genomics for the drugs we use earlier? So this is all about optimizing to the individual secondary and primary prevention. And so it's a good thing for our patients, and that means there is going to be less likelihood of further strokes, which will be great for the population, but also us working in frontline stroke medicine. As opposed to concern, in fact, I've switched entirely to thinking about how do we make this happen safely and efficiently for our patients, and ultimately that will mean for us as well working in stroke medicine. So Anthony, if we may go on to the next slide, please. So many of you working in stroke medicine will know all of these facts on the screen, and apologies for going over them, but some of you may be new to the reality of the burden of stroke disease in this country. So in the space of this webinar, there will be 15 people in England that suffer a stroke. And of those, we know that a third will be dead at a year. And of those that are left, half of them will be significantly disabled. That is a huge burden to the individual, their families, and to us in health and social care. And we, unfortunately, are going to have more work to do in the future because of the aging population, and because we have been so successful over the last 2 decades in reducing death. We are going to see the prevalence and those living with the disability of stroke significantly increase in the next 10 years. So this is not only a personal cost to them, friends and family, but it's also societal cost with regards to financially to the NHS. So it's all of our business to try and do everything we can to reduce the continued rising prevalence of stroke. Next slide, please. So as a National Stroke Programme, we work across the stroke pathway, and many of you will see evidence of that either in the hyperacute side, the pre-hospital side, or in rehabilitation and life after stroke, working with our third sector partners. We have within NHS England a prevention and long-term conditions board and domains of work of which stroke sits within, but we work very closely with our cardiovascular disease prevention group, which are together trying to tackle the reversible risk factors for all vascular bed disease. And of course, they are very similar with regards to our top 3, and that's of course hypertension, atrial fibrillation, and hyperlipidemia management. We also need to target specifically our patient population that have had a stroke or TIA, specifically to try and reduce them going on to have their second and third event. Next slide, please. So where are we as a National Stroke Programme with regards to prevention? So a few basic facts, and I'm grateful for colleagues who have published work from the South London Stroke Registry. also Global Burden of Health and Kathy Sadlow's team, which have looked at the efficacy of some of these agents. But the reality is we've got an incidence of 1.7 per thousand in this country, which equates probably to a risk of 1 in 4 men and 1 in 5 women at some point in their life having a cerebrovascular event. We know that about 1 in 8 of all strokes are preceded by a TIA, and that's not a funny term, that's a confirmed TIA. We also know that the risk is front loaded after your TIA for your risk of either having another TIA, but more commonly a full-blown disabling stroke. We know that 25% of patients do go on and have their second event at some point in the future, despite some of our efforts. And we also know that if we address those 5 key domains of hypertension, not smoking, weight reduction, and nutrition and exercise, we would be able to, if not entirely prevent, but delay cerebrovascular disease. And that's why we talk about this. 4 out of 5 patients could have avoided their stroke, and I'm not actually convinced we can avoid it entirely, but we can certainly delay it into the latter few years of life. And of course, that is our goal, is that we reduce the lives lived with disability in the population, not necessarily increasing life expectancy per se. And then the other thing just to point out is that some of you, when we're used to talking about some of our interventions, and let's take the most efficacious of all interventions in stroke medicine, and some of you know what I'm going to say here, is mechanical thrombectomy. So a number needed to treat of 2.6. And when we take some of our preventative pills that we give our patients, it absolutely compels potentially for the individual patient into relative insignificance. So Clopidogrel, number needs to treat of 50 for any cardiac event. For stroke specifically, it's a number needs to treat of 200. However, on a population basis, because stroke is so common, this is a really important intervention. So, and that is why we do prescribe all our antihypertensives and our statins and our antiplatelets. Yes, to help that individual patient, and on a population basis, because it's such a common disease, it has real benefit. Next slide, please. So, what do we do about managing patients with an ischemic stroke? So we're fortunate that, and I can see some on the call who have edited the updated national guidelines for stroke last year, published last year. And we thought we were quite clear in our minds what we did when it came to non-embolic, non-atrial fibrillation associated ischemic stroke, and that was that patients had long-term Clopidogrel, 75 milligrams once a day. There might be a small group of patients that couldn't tolerate Clopidogrel, and they had aspirin. And we were, and that was our rationale and reckoning. Then there was a guidance to suggest that we should consider people who have a recurrent event whilst taking Clopidogrel, and of course compliance is really important here. I'm not sure how often we all really inquire of our patients whether they're actually taking the medicine before we think they have had an agent failure, where of course it may well have been nothing to do with the agent. It was our failure to empower that individual to take their medicine, which was one of the problems. But there was a guidance here to suggest that if you do think that your patient was taking Clopidogrel regularly and they've had another event, that we should consider Clopidogrel resistance and potentially test. And that was how we were operating, many of us for many years, and the guidance, national guidance, supported that as of spring last year. Next slide. The only other caveat to that is, of course, because we are front-loading our efforts in TIA and minor stroke, because of the high risk of recurrence within the first few days, and probably up to 3 or 4 weeks. The guidance and many of our practices was about dual antiplatelet therapy for that initial 21 days. And hopefully many of you will have read this guidance and will be aware that the idea was a loading dose of 300 milligrams of aspirin and clopidogrel, then 75 milligrams of each for 21 days before slipping down to that longer term profile of just single agent clopidogrel. And the guidance also went on to suggest that in those patients, there was an alternative to the clopidogrel and aspirin for TIA minor stroke of using tiagrelol plus aspirin, then followed by tiagrelol BD or single agent clopidogrel if there was a reason why you couldn't use clopidogrel and aspirin to start with. So we were, I suppose, as a stroke fraternity, reasonably confident with this guidance, and many of you will have moved already to dual antiplatelet therapy for TIA or minor stroke for the first 3 weeks for many months / years. And of course, we were then presented with the NICE guidance. So if we move on to the next slide. So, and of course, instead of the NICE guidance suggesting that it was only in patients who have had a recurrent event on clopidogrel and were compliant with clopidogrel, the NICE guidance really did make a convincing argument for us testing patients before we put them on long-term clopidogrel. Now, the good news is that NICE were very collaborative with their working with us within the stroke community, and they understood the significant shift change in our practice to deliver this. Those of you who have read the NICE guidance will see that they were quite explicit with regards to just those patients with a new TIA or stroke. This isn't the hundreds of thousands of patients that are already taking clopidogrel. And the argument being is that because one's risk is so front loaded, if you've been on clopidogrel for 6 years and you did have a stroke or TIA in the first place, and clopidogrel wasn't working, you'd have probably had another event by then. Therefore, you're probably in the group that it works. So it is just for those new TIA or stroke patients. So what are we talking about per year? Well, we're probably talking about 60,000 patients who have had a stroke and probably 40,000 that have had a TIA. So that's probably the volume of patients we're talking about. And NICE were very clear that it should not alter our current practice, i.e. prescribe the drug, but what we should do is test patients at some point during that early journey to ensure that if they are resistant, poor allele function, we think about an alternative. And remember, if those patients with TIA or minor stroke, they will be or should be on dual antiplatelet anyway. So potentially you do have a short period of time to do the testing, and they would still have an antiplatelet on board, even if they were failing to respond to clopidogrel. But we really do, in the real world, think that this needs to be done within 3 weeks when they're on the dual antiplatelet therapy, so that we can make sure that the next agent we choose is one that they are going to get benefit from. The other thing to just highlight is that NICE suggested that lab-based testing was the preferred option. If there was a failure of ability to deliver this, then near-patient testing may be offered. And again, they talk about 2 different point-of-care testing kits. So that was the background. I'd just like to enthuse with all of you, I think this is a really good thing for patients. And if it's good for patients, it's good for us who care for those patients. So I'm going to hand on to Vidya, and then we'll take some questions. Thanks, Vidya.
Thank you so much, David. And I think you've made such a fantastically compelling case for why this is such an important service to design and develop and get right. And I really like the figures and statistics that you've shared with us. So thank you so much for that. And Vicky also wanted to say, I really enjoyed some of the things you're talking about, what the future holds for precision medicine in the NHS. And it's really exciting that stroke is the place that we're, doing this to start off with, and hopefully colleagues that are on the call can recognize that that's a real opportunity for the stroke community to really be a leader in this space. Fantastic. So I'm going to now talk a little bit more about what we are doing in a little bit more detail, more specifically around how do we put this into practice. So this is mainly aimed at colleagues that work within stroke services, providers of NHS stroke services, who are not part of the national pilot. The pilot is a small project, but who are, of course, going to be expected to deliver this as a diagnostic service in the near future. So this is really to provide you with some background about what we're doing to help that implementation in the short to medium term. My name is Bidea. I am a doctor and clinical innovation lead at the University of Manchester. And together with Emma Parnell, who is a service designer, I've been leading this project to work with 4 pilot sites to really try to understand the operational processes of how do we put this into practice. And as David said, when this was first published and first released, as you can imagine, trying to introduce a new diagnostic service, which is innovative and really transformative, comes with significant challenges, particularly in a system that is already overburdened and already under extreme pressure. So we wanted to try to have a conscious approach of introducing a service that not only is implemented successfully, but also adopted and therefore has an impact on patients. So what I'll cover today is I'll go through a little bit of context, and David has already set the scene excellently with a clinical background. I then want to talk a little bit about our approach, because I wonder whether it is slightly different to perhaps how we've done implementation in the NHS in the past. And that's really some of the feedback that we've had from colleagues so far. I'll give you a bit of an overview of the project itself, and then we'll go through some early feedback that we've had from the sites that we've been working with, and hopefully you'll find that interesting, and we'll close with some next steps. So, as you already know, we all respond differently to medicines, and our genetic code or our DNA plays a role in determining that response. Specifically in the context of stroke, the CYP2C19 gene has an impact on how clopidogrel is activated, and therefore how effective it is at reducing the risk of future events. Within the laboratory or the genetic community, this is often described as a metabolizer state, or sometimes as loss of function alleles. But the phrase that we hear commonly used in the clinical front line is clopidogrel resistance, just as David has already highlighted. And that's really the phrase that we have encountered colleagues on the clinical front line using regularly. So we know that testing for this gene change can allow us to ensure that the right patients receive clopidogrel, whilst others that are not going to respond receive appropriate alternatives, and therefore reduce the risk of stroke. And some of the numbers around this, I think, are quite compelling. So this gene variation in the CYP2C19 gene is very common. Around a third of patients within the UK population have CYP2C19 loss of function, in other words, or have clopidogrel resistance. And this number goes even higher if we look at people from ethnically diverse backgrounds. So, for example, patients with a South Asian ethnicity have an even significantly higher risk of having loss of function. And that's important because this then translates into an increased risk of having a recurrent stroke. And this was all very carefully evaluated as part of the NICE evaluation process. And based on that, this is the NICE guidance that's already been shown a couple of times to you, and many of you will be familiar with. And certainly for someone like me as a practicing clinician, this is really exciting to see, because this is genetic testing at the clinical front line. This is the use of genetics in acute medicine, which is really quite different to how we've used genetics historically. So to be able to apply that into this setting and really make a difference to patients at scale is really quite transformative. And I think as an NHS, we've got a real opportunity to be a leader in this at a system level, not just as an individual provider level. So that's something that I'm very excited about. So the question that we asked ourselves, well, the NICE guidance talks very much about what we should be doing. David has talked a lot about why this is an important thing, the potential for clinical impact, potential for patient care, as well as population health. And then the NICE guidance talked about, well, what do you have to do? Well, you have to test all patients that are admitted to hospital with a stroke or a TIA. But the question that we've then really asked ourselves is the how question. Well, how does the NHS implement such a diagnostic service as part of everyday care? How do we translate that NICE guidance into something that is part of the machinery of NHS services on a daily basis? So the approach that we have taken is to look at other industries where perhaps they work in a more iterative or incremental fashion. And many of you will be familiar with the term minimally viable product, and we've borrowed that phrase, and we're designing this project as a minimally viable service. So we're working directly with those that will be delivering the service, the clinicians, as well as those that will be receiving the service, which are the patients, to really understand what the operational challenges are, what the day-to-day workings of their clinical practice are today, what their experiences is, so that we can design something alongside with them that is actually adopted and works for those that are going to be having to use it on a daily basis. We have 4 pilot sites. I'll share a little bit more about those in a moment that we're working closely with to design a first version of this service that we will then continue to evolve and improve over the course of the next few months. Our ultimate aim is to summarize that learning in what we are describing as an implementation guide, so a document that can then be used by other providers of stroke services across the country to hopefully have a head start and a really good foundation to be able to implement this in a way that works for the people that will be delivering it, with hopefully the least amount of friction, because that's something that we're constantly very conscious of. Is, as I mentioned, NHS services are already under significant pressures. We want to try to introduce things that do not pose an additional burden on frontline staff, and especially with the kind of numbers that we've already heard, 60,000 strokes a year, 40,000 TIAs a year, that is a large volume of additional potential work that we want to integrate as seamlessly as possible. So the project is led by the Network of Excellence, which Vicky highlighted in her introduction, which is funded through the NHS Genomics Medicine Service based out of the Northwest. And we are supported by the NHS Stroke Programme as well as the Genomics Unit. We have just started the project last month, where we have selected 4 pilot sites across England, which are St George's, based in London, Exeter, Doncaster, and Salford. We have 1 laboratory site, which is part of the Northwest Genomic Laboratory Hub, and the site is physically located in Liverpool. And out of those 4 sites, Exeter, Doncaster, and St George's will be doing laboratory testing, and Salford will be doing point of care testing. And this mix is really based on the fact that we wanted to have, firstly, a wide geographic spread across the country. We wanted to ensure that we had sites that served different population groups, so rural versus urban, ethnically diverse versus perhaps more deprived. We wanted to ensure that we had good coverage of that. And we also wanted to have a range of stroke units, so stroke units that have a hyperacute unit, stroke units that are just acute stroke units, and ones that have rehab within the same organization, as well as ones that have rehab outside of their trusts. And this was really so we could understand a mix of challenges as well as opportunities within different settings across the country. We wanted to provide service design support for all sites, so we didn't want to completely leave them unsupported. We wanted to try to help them implement this and think about things in a more systematic way. So Emma and I have been visiting all the sites physically. So we had a nice tour of the country over the last couple of weeks, going to Exeter, Doncaster, and London, and obviously Salford is local to me in Manchester. And that's been absolutely fascinating. From a designer's perspective, it's been really, really valuable to actually be on the shop floor, just to observe how the ward works, how bloods are taken, or how patients are moved through different clinical environments. And that has really helped inform the way we've been able to support the sites with implementations. We are now going to get together with the different sites to think about the pathway in slightly more detail in design workshops. So we had our first one with one of the pilot sites this morning, which was really, really fruitful. We've got an anticipated start date for testing for the first pilot site in December of this year. So we're keen to try to start testing this side of Christmas, though we're also very conscious of the fact that, of course, there are significant additional pressures around the winter months, and we have a lot to put into place before testing can commence. So we are conscious that though we've got a target date, we are also flexible with regards to what is possible and realistic in the real world. We're aiming to undertake 1,000 laboratory tests over the process, over the period of the project, and that is running from maybe December, January time up until April next year. And just to share a little bit of context for those of you that are aware of the NICE guidance, as part of that publication, there was also a case study of a implementation in Scotland, where colleagues have indeed been doing this genetic testing for a bit longer than we have down in England. And over a period of 12 months, they tested around 700 odd patients. So we're looking to do 1,000 over a course of 3 to 4 months. So that kind of marries in terms of the sizes of populations and geography served. So what have we done so far? As I said, we've been to the different lab testing sites. We've completed our analyses from the workflows and the clinical conversation that we've had there, and we've mapped those processes out. We've had our follow-up workshops, and we had the first one today, as I mentioned. And what's been really interesting about this process is we've worked not just with the clinical stroke team, in other words, the doctors. We've been very active to make sure that we include pharmacy teams who are increasingly becoming central to this implementation, as well as junior doctors, which has been particularly interesting. Again, thinking about genetics from a more historic perspective, often this is a test, or these are tests that are ordered by specialists. Whereas now you have a situation where actually it might be an FY2 doctor or a resident doctor that's been asked to complete a test request form for a genetic test. So this is a completely new set of end users. We're also in close conversations with the lab to try to understand their needs and requirements as well. And we're expecting to deliver outputs next year, which is a live service at 4 sites, an implementation guide, as I mentioned, as well as supporting information for Vicky, as well as and the wider team to support commissioning decisions. So this is just to share with you a picture of one of our junior doctor colleagues at one of the pilot sites, who we were asking them to have a look at the test request form. And this was really, really valuable to do, because this is the kind of work that we maybe don't always do in such detail when we are implementing new services or designing new services. But actually, when you do this, you uncover that there are actually lots of barriers to implementation that you perhaps hadn't appreciated before. So this form was considered to be quite complicated and not familiar for clinicians that do not routinely order genetic tests. So we've since been trying to redesign this and work with the lab to see if there are alternative ways of designing this so that it is more accessible to a new range of end users. And we've tried to think with the site about the service from an end-to-end perspective. So starting all the way from patient selection, so how do we decide who to test as we try to think about a phased rollout? Is it best to start in the TIA clinic? Is it best to start on the ward? Is it best to start with patient with recurrent strokes, or rather with minor strokes? So these are questions that we're trying to figure out. And this might again be based on local nuances and how services are set up locally. Similarly, about test ordering, well, who's responsible for completing a test request form as part of this pilot? And certainly for the near future, the test ordering is done on paper. And that is because we do not have necessarily a digitally connected digital infrastructure. With regards to samples, how are samples taken? Who actually takes a blood sample? How is that packaged up? And how does that get sent over to the central lab, which is in Liverpool, as I mentioned? And then how are results received? How do they come back to the requesting center? Do they come back by post? Do they come back by email? What's the ideal workflow to bring those results back? And that is certainly one of the things that, of course, we're thinking about, is how can we try to integrate this in a digital way as part of this process. Then there is a question about, well, once you do have the result, whose responsibility is it to action it? Is this perhaps a pharmacy first services as part of the role of the stroke pharmacist, or is this responsibility of the consultant or the registrar? Or these are again questions that we're unsure of. And then also how these results recorded and communicated to other healthcare professionals, such as primary care, for example. And then finally, around prescribing, well, how do we alter a prescription? One of the pilot sites, as I mentioned, is more rural, and patients are sometimes several hundred miles away. So asking them to perhaps come back to pick up an alternative prescription may not be possible. So how do we do that? How do we actually implement a prescribing process? and ensure that we communicate this effectively to patients. And this is a snapshot of a pharmacy colleague looking at a genetic test result. And again, similarly, this is the typical way genetic reports are produced. And again, being able to get their feedback on what works for them, whether it's clear or not, has been really, really valuable. So here are some of our early findings. And again, we're still very early in the project. We're only a month and a week or so in. So one of the things that we've been trying to talk about to colleagues is that there is an inclination to treat this as a project, as a specific pilot with a start date and end date. But really what we're trying to impress is that we want to try to think about this as a live service. So we don't want to wrap this in cotton wool and say, oh, well, for the pilot, the junior doctor can take the blood sample and the consultant can receive the result, because that's not sustainable. That's not scalable. We want to try to think about not just a viable service, but a scalable, viable service, if that makes sense. Similarly, there's a question around patient information. This is a new diagnostic service. So what should we be telling patients about this? How much detail do we need to share? This is a test, a narrow genetic test to guide the prescribing of a medication that they're going to receive. Do we need to make a big deal of this, or should this be more narrow in our communication? We're not testing for several other genes. We're only testing for a specific gene. So exactly what type of information do patients want to hear, and what is appropriate to share with them? The turnaround time may pose significant challenges for logistics and operations and clinical practice, because as we've already heard, and the prescribing of clopidogrel happens at different time points. For minor strokes and TIA, they'll be quite early in the pathway, and for other events, it might be later. So does the turnaround time affect the timing of prescribing? And we already mentioned a lack of current digital infrastructures. We're currently working on paper forms, but we're certainly very keen to continue to think about how processes can be digitized. And currently there is no formal agreement on alternative prescribing. That's something that we're thinking about. I know that Vicky will touch upon this as well. So at the same time, we've tried to translate some of those challenges into opportunities. So even though there are some local differences, there's also lots of similarities. So even though there is depends on how services are set up locally, staffing resources and local prescribing practice, a clear pattern is starting to emerge of how this could be implemented relatively universally. And we look forward to sharing more of that as we go forward. We're starting to think about trying to get people to work at the top of their competence, which I think is a principle that I've really enjoyed to think about. So trying to make the most of resources. So we know that there is, in most hospitals, a phlebotomy service. So rather than trying to think about a junior doctor taking, a resident doctor rather, taking a blood sample, let's try to integrate this into existing phlebotomy services. Similarly, pharmacy colleagues are expanding their scope of practice. So being able to incorporate this as part of their practice is something that's been really enthusiastically received. I've already talked about trying to think about how we do something that is going to be scalable, rather than just try to think about a very specific project with an end point and a start point. And we're also conscious of the fact that point of care has significant opportunities and potentially benefits, particularly in those clinical scenarios where a prescribing decision happens soon. So there is an opportunity that there may be a mix of services, and there are cases where point of care works better, and there's maybe situations where lab testing works well as well. So we are very conscious and open to feed all of this back as part of our learning. Great, so I'm going to stop there, and just before we go on to questions, I'm going to hand back over to Vicky to talk about some of the other aspects important to implementation, and then we'll be very keen to take your questions and have a discussion.
Thanks, Fidea. So I'll be very quick. I just wanted to touch upon some of the questions that might be possibly already popping up in people's minds in terms of the approach, I guess, of implementing genomics and medicines optimization as a linked and joint priority. So we've talked a lot today about obviously the integration into clinical workflows and pathways, which is, essential because we want this to form part of mainstream care. We don't want it to disrupt your normal processes. We want it to enhance them. Research and innovation, the evaluation approach and implementation. But obviously we think about lots of other things alongside. And just to clarify that the pilot, although as Vidya has highlighted, the main outputs are the implementation pathway and the informing commissioning and our approach, it's also informing lots of other things around this, thinking about, although we don't have the digital infrastructure at present and we're using paper forms, how we'll do this in the future, what we need for our workforce, and continually raising that awareness and engagement. So some of the key areas that we've highlighted that we need to keep building alongside, because we're aware that obviously you'll get the implementation guidance and you'll be able to use this at a local level, but sometimes it's really helpful to have, again, consistent other national resources to support your localized approaches. The things that we've been thinking about, and welcome any other thoughts, is is there a need for national clinical guidance or a consensus statement, particularly around the use of alternatives? And hopefully we'll learn from the pilot in terms of that kind of process of decision making beyond clopidogrel. What level of additional information may be helpful, what workforce training and education support is needed. We're aware that this is kind of genetics just coming in almost out of nowhere into a very different part of the NHS where it's been used previously, and so we want to make sure that everyone has the tools to feel capable to deliver this to patients. As I've mentioned, although we're constantly thinking in the background, we have a big digital vision in genomics, and this is a key use case for us in terms of should this information look like, how do we code it, how do we transfer that information so it's in the patient's record and usable. Some other points which I've also seen pop up in the chat: if and when should the result be used for other clinical indications? So thinking about some some general guidance or clarification around that point moving forward, being aware that CYP2C19 is obviously a gene that encodes an enzyme that metabolizes other drugs as well. We're continuing to work with NICE in terms of clinical implementation and resources that may be needed, and also the wider resources that everybody uses every day, and what information we need to make sure is in there and accessible, so you're not having to go somewhere completely different. So what's needed in the BNF, etc. And that was it. Let's go to questions.
Great, thank you so much, Vicky. The chat is blown up with questions. So that is good. So I'll try to theme them up, and it's actually great to see some discourse and people actually starting to answer questions within the chat to each other, which is actually really, really helpful and interesting to see. One of the questions that lots of people are talking about is the difference between point of care and lab test. So I can start by providing a perspective. So at this point in time, we recognize that from an implementation perspective, there are benefits to point of care and there are potentially advantages to lab testing. There are considerations around scale. So if we are doing this at scale, what are the potential investments that need to be made, both if you were going down a point of care route, as well as if you're going down a laboratory route? And these questions are currently unanswered. So that's part of the work around the pilot, to try to understand, well, what would this look like at scale? And together with that, one of the other considerations that, I suppose, and Vicky might want to come in on this, from kind of an NHS perspective, is we need to also think about, well, how do we put infrastructure in place that supports, of course, genetic testing in stroke, but perhaps also in other contexts as we start to expand the role of pharmacogenetics. So there are a few additional considerations when we try to think about point of care versus lab, and these are the things that we're trying to figure out at the moment. And this is still all very new, and it's it's really cutting edge, and it's going to take some time to figure that out. And I think the best way to do that is to be out there in the real world, which is why we're doing this pilot, to really learn about, well, gosh, what actually happens when we put this into practice and put some of that theory into practice. Vicky, did you want to come in on that at all?
Yeah, thank you, Dana. That's a really helpful summary. I suppose just to add to that, so obviously in the Joint Medicine Service we currently commission lab testing, and part of this thinking, as I mentioned, with pharmacogenomics is how we scale that up. So that's one of the considerations in order to get those tests out at scale. I can see that someone put in the chat, well, what could the advantage be of lab over point of care? Point of care is quicker, but there are some aspects. So highlighted in the NICE guidance in terms of, there's other thoughts that we're having alongside in terms of what can be tested. So in terms of the scope of the star alleles that we will test, and finding out basically what we can do in a lab at scale versus what is in a point of care testing machine, accessibility across different settings, thinking about the longer term future of PGX. So really from this pilot, understanding what the realistic implementation timelines are, when is this result needed, when does it fit back in, will really help inform our thoughts around kind of how this is best delivered to support services.
Vidya, before we bring in Beverly, and we do want to hear from Beverly, being a thrombosis expert, may I just reflect on all the, and you're right, it has blown up the chat, which is great, lots of questions. If I could be really pragmatic here and suggest the whole point of us having these pilots is to answer many of the questions that you all have. And there's lots of chat about why bother, why don't we just move on to another antiplatelet? So I would just suggest everyone pause. Let's wait for these pilots, which is a rapid pilots, to deliver some answers to these questions in the new year. If you're desperate to prevent patients having stroke, I would make sure that everyone's treated to their numbers for hypertension, their lipids. You've hunted for your AF, and you put all your efforts into that, not into this right at the moment. And I would wait for the pilots to deliver. It will give us an idea also what other agents are being used. And it may well be that come springtime, there is a consensus about what is the most efficient use of your time for patients regarding antiplatelets, but also testing. So I wouldn't rush into anything. There's far more things that have greater patient benefit that you could all be spending your time on at the moment until we have the answers. And so I know some of you are already testing through deals you've got with local point of care testing companies. That's fine, except there's lots of unanswered questions that this collaboration is hoping to answer. And to just put into context, Clopidogrel versus aspirin probably saves in the region of 7 patients having a stroke per 1,000 patients treated 2 years. Okay, so that's the difference between Clopidogrel and aspirin. So if we're going to get really, really obsessive about something, I think potentially let's manage our hypertension, find our AF, manage our lipids right at the moment, and let's wait for these pilots to actually deliver to answer many of these questions. Thanks, Vidya.
No, thank you. I completely agree, and thank you for taking that and mentioning that, because absolutely a lot of these things are undecided. They are not figured out yet. This is new. So we are trying to learn, and we're very keen to share, which is why we have this webinar today, and we'll continue to have updates like this. Beverly, would you like to come in, please?
Thank you. Sorry, my chat doesn't work. I can't see any chats and I can't put a question in it. So I'm Prof of Thrombosis and Hemostasis at King's, and I have got 2 questions. The first is, why are the regional genetics labs not running this test? Because they provide genetic analysis for free. And I guess that somebody somewhere has decided this is too expensive. So we are setting it up in our lab. And the question is, there are multiple polymorphisms that cause problems and with Clopidogrel, and we have a multi-ethnic population in London. So we're going to try and run as many as we can and we can afford, but it's going to cost about £100 a test per patient, which we will have to cross-charge to the stroke department. Has anyone thought about all of these funding consequences? Thank you very much.
Would you like me to come in, Vidya?
Please, Vicky, yeah.
Yeah,
thank you, Beverly. There.
So absolutely, all of the regional genomics hubs, so our genomic laboratory hubs, provide genetic testing. And I don't know if you had a chance to join at the start, but in terms of the process of us adding tests to our national commissioning list of tests, there is a process, as an application process. We didn't have an application in this case, we had the NICE guidance. So the NICE guidance has provided us that evidence-based recommendation. And now we're looking at the implementation and impact assessment, which is the same thing that we would do if something came through the application process. So that part of this, and part, as Vidya has highlighted, the understanding from the pilot will help inform us in terms of the approach to commissioning. So that's what we are looking to get. And absolutely, in terms of the potential star alleles that we may need to test for, that's kind of why I highlighted why we're looking at lab as well as point of care, which is what NICE highlighted as well, and one of their reasons for lab testing. And that's something again that's running alongside is understanding, you know, what can we do with the technology and the assays that we have, what can we deliver, and what does that look like? So we're going to take all of this information, and that will all kind of inform approaches to commissioning going forward. But it's great that you're making you know, such positive steps forward at a local level as well.
Fantastic, thank you very much. And just to add to what Vicky's just said, I know there is this, because also at the pilot sites there was this potentially current misconception that point of care in some ways is inferior from a quality perspective, or from a being able to check for ethnic variation perspective than lab testing. And at this point in time, that's not the case. So at this point in time, the point of care test, in fact, is potentially has a test for a wider range of star alleles compared to the lab test at this point in time. But of course, there's an opportunity for that to change in the future. So it's just to make sure that people are aware that it's not like if you're having point of care, that is an inferior test than the lab test. I can see Kavan wants to come in. That will have to be the last question, if that's okay, before we close.
Thank you for taking my call. I'm a stroke pharmacist in Buckinghamshire. There's lots of comments on the chat. I think quite a few people are keen to do, and if you touched on, have already explored or looked to do point of care testing locally. Is there any scope for them to feed into what you're already doing in terms of protocols and stuff to get a larger population if they're already self-funding some of that, in terms of at least sharing protocols and stuff, because it might be that your numbers are then higher and we're sticking to the same format? And the second question is, I assume that the patients in the pilots that you've got, they're being optimized with their blood pressure and lipids, and is there any scope to look at testing for lipids, like in terms of genomics, for which lipid therapies would be optimal for them?
I think that's a great suggestion. So that's not within scope for what we are doing at the moment, though I think that's a very sensible suggestion, and something that, you know, perhaps some innovators want to look at into the future. Certainly thinking about using what people sometimes talk about, cardiovascular pharmacogenetic panels, or kind of stroke pharmacogenetic panels, where you look at multiple genes that relate to other medicines that are also commonly prescribed in those care settings, is something that we should definitely think about in the future. But that's wasn't part of the NICE guidance. It's not part of what we're doing at present. And with regards to people feeding in what they're doing in their local settings, absolutely, please feel free to reach out to me. I'll put my email address in the chat. I'm very happy to hear what people are doing and share their learning. So very happy with that. Fantastic. We're exactly on time. So I'm going to end by giving everyone a really big thank you. Thank you to our speakers. Thank you, David. Thank you, Vicky, for joining me today. Thank you, everyone, for attending this webinar. We're very keen to keep you updated. So we've had lots of feedback today, and we're going to try to digest the chat as well, and then hopefully try to follow up with another webinar in the new year to keep you updated. Thank you, everyone. I hope you have a good day.
Thanks, everyone.